Good afternoon, everyone. My name is Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Finding Recovery in the Face of a National Crisis, the Use of FDA-approved Medications in the Treatment of Opioid Use Disorder. This webinar is being made available through a collaboration of the Office of State Court Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have any questions, please send them to the presenter and the host by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options have been posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. You must be able to view the PowerPoint in order for you to receive credit as well as the audio. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the OSCA to help participants track credits earned through attendance. We host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of the registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Wednesday, May 22nd. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE broker. When you register with our site for the first time, you are certified with the Florida Certification Board or licensed outside the state of Florida. You don't need to provide your certification number when you register with our site. Note, please, the WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenter, Zachary Talbott. He is a native of Eastern Tennessee, having graduated high school in Maryville, Tennessee, and then with his bachelor's degree from the University of Tennessee at Knoxville. Zach received his graduate education in clinical social work from Walden University. Zach opened 2 outpatient opioid treatment programs in Chatsworth, Georgia, and Murphy, North Carolina, where he served as the program sponsor of both OTPs and served as program director of the OTP in Chatsworth, Georgia, until August 2018, when both OTPs were acquired by Baymark Health Services MedMark Treatment Centers. Zach continues to serve as the Treatment Center Director for MedMark Treatment Centers, Chatsworth. Zach is a certified alcohol and drug counselor, level 2, a medication-assisted treatment specialist, an electronic certified alcohol and drug counselor, and a certified clinical supervisor through Alcohol and Drug Abuse Certification Board of Georgia, a certified addiction counselor, level 2, through Georgia Addiction Counseling Association, an international certified alcohol and drug counselor through ICNRC, a registered addiction specialist through the Green Institute, and a certified medication-assisted treatment advocate through National Alliance for Medication-Assisted Recovery. Zach currently serves on the executive committee as treasurer and full board of directors of the Alcohol and Drug Abuse Certification Board of Georgia, the Georgia Affiliate Board of the ICNRC. Zach also serves on the executive committee of the Board of Directors of the Opioid Treatment Providers of Georgia, the Georgia State Opioid Treatment Providers Association, and Georgia chapter of the American Association for the Treatment of Opioid Dependence. Zach has been a Recovery Month planning partner with the Substance Abuse and Mental Health Services Administration since 2014. Zach enjoys life in long-term recovery from an opioid use disorder himself and lives in Dalton, Georgia with his partner Chip, their 15 and 10-year-old sons, and their 3 dogs, Mary, Mocha, and Layla. And now I would like to turn the presentation over to Zach.
Okay, thanks. I hope everyone can hear me well. If you can't, please leave a chat and we'll make sure. I appreciate the opportunity to talk to you all today about this important topic. I just got an I am not able to hear in the Q&A.
Yeah, I'll address the audio.
Okay. All right, good. Okay, but you can hear me. Okay, so all right, so with that said, we have limited time. We want to make sure that you all get the content that you need and get out of here on time. So I'm going to jump right in. We're specifically talking today about the FDA-approved medications for the treatment of opioid use disorder, which is just one form of medication-assisted treatment for one substance use disorder. And there are also medications approved in the treatment of alcohol use disorder, as well as tobacco use disorder and nicotine dependence. All right, so today our learning objectives for CEs, we're going to be able to, by the end of this, describe the 3 FDA-approved medications for opioid use disorder and their similarities and differences. We're going to be able to explain the damaging effects of chronic use of short-acting opioids on the brain and how the use of MAT can facilitate the healing of the brain's endogenous or natural or internal opioid system. And we're going to be able to provide a description of how medication-assisted treatment in a comprehensive treatment environment addresses all the aspects of opioid use disorder as a biopsychosocial disease. And lastly, explain how the use of MAT fits into a recovery-oriented focus of treatment while describing the importance of individualized pathways to recovery. There just is no one-size-fits-all. So since I never know where all of our participants are in terms of knowledge, I want to hit the base on opioids because some people, even in the field, sometimes are confused, opioid versus opiate versus different different things. And so I want to start with just the basics to make sure what we're talking about here. So opioids are a class of drugs, and that includes opiates, that include things like heroin, synthetic opioids like fentanyl, which we're hearing a lot about on the streets right now, and its use in heroin and even pills that are made of fentanyl that are made to look like other pills, as well as prescription pain relievers that are available by prescription, such as oxycodone or its extended release name brand version, OxyContin, hydrocodone, and name brand of that is Vicodin, morphine, and many others. So for these drugs are all chemically related, and they ultimately all interact with the brain's opioid receptors, which are nerve cells in the body and brain. And we're going to talk more about those receptors a little later, but that comes back in. That's what all of these opioid substances interact with these same receptor sites. And so regular use of any opioid, whether it's a naturally derived opiate, so things that are derived from the opium poppy, like morphine and heroin, hydrocodone, those are opiates. And then opioids are man-made, typically. Other opioids are synthetic opioids. But regular use of these substances can lead to a physical dependence. And with chronic use and misuse, opioid pain relievers, as well as heroin, can lead to overdose incidents and death. Now, although this presentation today and webinar is not about opioid overdose and opioid reversal, it's about the actual medical treatment of these of opioid use disorder, I think it's important to point out that an opioid overdose can be reversed with the drug naloxone when it's given right away. Naloxone is also known by different name brands such as Evzio and Narcan. And I commend to each of you all, we're in the midst of an opioid crisis, to, on your own, research naloxone and where you can get your hands on some, how you can get trained in its use. Even if you don't think that you know someone that is struggling with or dealing with an opioid use disorder, you might be surprised. There was a story recently here in North Georgia where a nurse was driving down a local road, a highway, and there was a car pulled over, and she stopped to check. The person was in the midst of opioid overdose, and she was able to revive them by administering nasal Narcan. And so I always say a dead person can't recover. The point of all these treatments is moot, and everything we're going to learn today, if we can't keep folks alive until they are able to access and or willing to participate in treatment. So those are opioids. So then opioid use disorder is the official name of the diagnosis in the DSM-5. So the Diagnostic and Statistical Manual of Mental Disorders, which is from the American Psychiatric Association. And with the DSM-5 changing from previous versions, it no longer uses the term substance abuse and substance dependence. There's a lot of confusion around those words, but rather it refers to substance use disorders. And then they're defined on a spectrum based on severity and the number of symptoms or diagnostic criteria present as mild, moderate, or severe, and that ultimately indicates the level of severity based on the number of criteria that an individual meets. So some symptoms of an opioid use disorder and things that are used as diagnostic criteria during assessment are a strong desire for opioids, an inability to control or reduce the use of opioids, continues despite interference with major obligations or social functioning. We see ongoing opioid use despite catastrophic consequences in many of these individuals' lives. Increased tolerance, use of larger amounts over time. It takes more to get the same effects, which leads to the development of tolerance. A great deal of time is spent to obtain and use opioids, and ultimately then withdrawal symptoms occur after stopping or reducing use. Now, I would like to point out here, as we talk about this, that the tolerance and withdrawal symptoms, if those are the only two things present and someone is taking legitimately prescribed opioids for pain management or chronic pain, I want to make sure that in this discussion that we don't stigmatize pain patients that there is a group of people that have a legitimate medical need for opioid pharmacotherapy for pain. And so if the only criteria that are met is withdrawal symptoms and physical dependence tolerance, then that by itself, if they're legitimately prescribed opioids, is not considered an opioid use disorder. So when we talk about addiction versus physical dependence, a substance use disorder or an addiction involves a lot more than just going into withdrawals and being physically dependent. Someone can have those things, be physically dependent, and which would lead to withdrawals if they abruptly stop taking them, and still not necessarily have an addiction that's characterized by all of these other things. And so I want to look at the opioid epidemic in the United States before we jump into this, so we really understand the severity of what we're talking about here and the opioid crisis that's in the news. We also don't want to underscore the other crises. We need to remember that alcohol continues to be a leading cause of death and the #1 abused substance. But opioids have really risen in our public consciousness because they're affecting people in all walks of life across all socioeconomic status, ages, races. And so the opioid epidemic in the United States, so as many of you likely will know, we just don't get data very quickly, as most of this comes from the U.S. Department of Health and Human Services and the Substance Abuse and Mental Health Services Administration, or SAMHSA, which is within HHS. And so the most recent data that is currently published is 2017, because that was compiled and published towards the end of last year, 2018. So then hopefully by the end of 2019 this year, we'll have 2018 data. So there is a lag. And so by all accounts, we know a lot of this is going to be worse, but some things may have improved. But in 2017, we know that 11.4 million people misused prescription opioids, misused them. 2 million people in 2017 alone, 2 million people misused prescription opioids for the first time. 11.4 million people misused prescription opioids. That's a double bullet point. Sorry about that. 47,600 people died from overdosing on opioids in just that 1 year. Just under 50,000 people died from an opioid overdose. And 2.1 million people had a diagnosed opioid use disorder that we could track. So again, many more people have an opioid use disorder than the numbers that we actually track. Because to know that, that means they would have had to have had some form of assessment, treatment, screening, and so many people we know never even get that far. So 2.1 million on record. 886,000 people used heroin. We had 28,466 deaths that were attributed to overdosing on synthetic opioids other than methadone. So this is your fentanyl. And look at the numbers just in 2015 that I put there. The drastic, almost 20,000 more deaths attributed to overdosing on synthetic opioids other than methadone. 81,000 people used heroin for the first time. The 81,000 people that used heroin for the first time, it's interesting that that number is up, but the deaths attributed to overdosing on heroin is up as well, but not nearly as much as the deaths attributed to overdosing on synthetic opioids. As you can see on the second bullet point on this slide versus the fourth, that really this is why there's such a concern and focus now on synthetic opioids like fentanyl and the other analogs, carfentanil, that many of the street heroin and the drug supply, the cartels have figured out it's much cheaper to synthesize fentanyl in a lab. So when we're talking about these synthetic opioids, it's largely not fentanyl like you would get in a legitimate Duragesic patch from a drugstore. We're talking about fentanyl that is typically synthesized in labs in other countries, sometimes even in the United States, and it is cheaper and quicker and more efficient to make fentanyl, many of the cartels have found out, than to go through the process of converting raw opium into heroin. And this is, the economic costs take even longer. And so the most recent that I could track down kind of total sum is 2013 data. So we know this is way, way, way bigger. But just to give you a snapshot, $78.5 billion with a B, dollars in economic costs thanks to the opioid epidemic. A lot of that's due to lost productivity, the costs of incarceration and health care, and a variety of factors. But $78.5 billion in economic costs, which we know is that number. Most experts estimate that's well over the $100 billion range now. And so you think about just the cost to society and what can we do, and the amount of treatment that we could give folks, or the amount of positive things we could do if we could keep those billions in our economy. And so this kind of really just breaks down what we talked about. A neat slide there from hhs.gov/opioids that kind of lets you see the snapshot that this is really an epidemic. And as you'll see the sources even on this slide that is currently posted 2019 on hhs.gov, that the most recent data we can pull from the National Survey on Drug Use and Health and mortality is 2017. So hopefully we'll have new numbers by the end of this year. So what can we do? What can we do to address this crisis? We're going to talk specifically about the treatment side of things today, but as you can see from the numbers, prevention efforts are important as well. And so again, this webinar is not about prevention, but we have to keep that in the back of our minds too. We have to support kind of a comprehensive approach to this crisis and how we can improve it. And a big key part is treatment, but that's not the only part. And so we need to support evidence-based interventions and practices. And I know some of you are probably like, evidence-based, that's all we hear. Every website of every treatment center seems to claim to offer evidence-based treatment now. And many do. A lot of grant funding, especially federal, that come ultimately from the feds, even if it's through a block grant to the state, require the use and implementation of an evidence-based practice or an evidence-based treatment model. And so what does that even mean? I think it's important for us to ask ourselves, as we are, whether for opioid use disorder or any other substance use disorder, what are we talking about? And so a really good definition that I particularly think lays it out well is that evidence-based practice is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. And so it means integrating individual clinical expertise with the best available external clinical evidence from systematic research. And so we're talking about not just finding one study. Any of us could probably go on PubMed or some other database of peer-reviewed journal, and we could find a single study or a single article or journal that supports or gives a nod to just about anything, a single study. We're talking about systematic research, something that has been shown in study after study after study after study, and it has been repeated, double-blinded, and repeated again. And so that's what we're talking about, the best available external clinical evidence from systematic research, not just a single study. And so when you think, does an organization provide evidence-based practice? Do they engage in evidence-based treatment? That's what you want to know. Well, don't just cite one study, or don't just claim you're an evidence-based provider. Tell me why. Tell me the proof. And you should be able to replicate it time and time again. But clinical expertise is an important part as well. Also, and this comes from Duke University, this particular graphic, is the patient's values and preferences. For something to be evidence-based, proven effective, you not only have to have the best research evidence available, you also have to have an individual's clinical expertise. If I don't have clinical expertise, I cannot take that best available evidence and then relay it to a treatment protocol. But in addition, the patient's values and preferences are important. For example, we talk about medication-assisted treatment today, which is one of the most evidence-based treatments in all of medicine as far as the number of studies that support it. But if I have a patient who belongs to a faith group that does not believe in the use of medication, right? We have to consider the patient's values and preferences as well, because we will never engage them in a treatment model that uses medications. And so in general, when we're talking about evidence-based practice, it's important to know what we're talking about. The best available external clinical evidence from systematic research, study after study after study, through the lens of the clinical expertise of an experienced and appropriately licensed or credentialed provider, be that a clinician or a medical physician. But we have to keep in mind the patient's values and preferences as well. So keep that in your mind as we work through this today and going into the future, what we mean when we're talking about evidence-based. It's not just a catchphrase. It's something that means something that's very important, and that it's when we employ practice that has been proven to work. So what if I told you all that I could offer you right now, and to this country, a treatment intervention or a treatment model when it comes to the opioid crisis that has been proven to result in a reduction in the use of illicit drugs, a reduction in criminal activity, reduction in needle sharing, a reduction in HIV infection rates and transmission, and hepatitis C as well. It's cost effective. It's not expensive. It results in a reduction in commercial sex work, a reduction in the number of reports of multiple sex partners, improvements in social health and productivity of the patient, improvements in other health conditions, results in a reduction in suicide and a reduction in lethal overdose. If I told you right now I had that, would you want to implement it? Wouldn't we all be on the bandwagon saying, yes, that's exactly the type of approach we need, something that does all those things for this opioid crisis that's affecting our nation? And the reality is that we do have such an approach. And I think sometimes some of the wordage, some of the language, some of the misinformation and stigma, which we're going to talk about towards the end, are so pervasive that we can't see the evidence. But as part of a comprehensive treatment program, and we're going to come back to comprehensive treatment program because that's key as well. This is more than just prescribing. Medication-assisted treatment with methadone and buprenorphine specifically, and we're going to talk about naltrexone a little bit later, but all this evidence is specifically for these two of the three FDA-approved meds, is an effective treatment for heroin and prescription opioid use disorder when measured by all of these things. And I cited just two studies, but again, study after study. The National Institute on Drug Abuse houses many studies. I would be happy to provide you further reading on that. I mean, there are so many, and we're going to talk about a few more as we go on today. But this is science. This is not opinion. This is not a theory or hypotheses. This is fact. All of these things have been shown to be associated with medication-assisted treatment with methadone and buprenorphine. Naltrexone's use is much newer, or at least an approach with naltrexone where there's actual treatment compliance, and we'll talk about that here in a little bit. But just for now, these two medications, methadone being the oldest and probably the most misunderstood and most stigmatized. That's why I focus on it a little bit today as well. And then more recently, buprenorphine, which started being used in the early 2000s and trials in the 90s, and it was used in Europe prior to that. They're an effective treatment when we measure these things. They work when they're used as part of a comprehensive treatment program. And so the Substance Abuse and Mental Health Services Administration that we were talking about earlier in the U.S. Department of Health and Human Services, they define medication-assisted treatment, or MAT, as a form of pharmacotherapy. So when we're talking about pharmacotherapy, that's the use of a medication in treatment. And it refers to any treatment for a substance use disorder that includes a pharmacologic intervention or a medication as part of a comprehensive substance abuse treatment plan with an ultimate goal of the person's recovery with full social function. So again, why, when we're looking at these things, we're talking about a comprehensive substance abuse treatment plan. And so SAMHSA, the U.S. Department of Health and Human Services, includes that again, comprehensive treatment. But it's the use of a medication as one intervention within a larger treatment plan. And I think that's important to emphasize again. And so when we utilize medications such as methadone or buprenorphine or even naltrexone, although it's a different approach we're going to talk about in a little bit, in the treatment of an opioid use disorder, it is critical that patients have access to comprehensive psychosocial support and counseling services. Patients receiving medication-assisted treatment exhibit reductions in illicit opioid use that are directly related to the medication dosage, the amount of psychosocial counseling, and the period of time that patients stay in treatment. And so we know that longer treatment times yield better results. Patients who have access to and engage in psychosocial counseling and other peer support have better results. And also, if you're going to use a medication, it has to be the proper dose. Like any other medical treatment, if you take Lipitor for your cholesterol, if it's not an adequate dose to address the symptoms and control the disease, the medication is not as effective as it should be. So we have to have individualized dosing protocols, just like any other medication for any other disease, but also these other things, and it's directly related to the cessation of illicit opioids. And so when we're talking again about evidence-based practice, medication-assisted treatment as an EBP is significantly more than just providing a prescription of medication. Now, because medication-assisted treatment can be offered in a variety of modalities, and when we're talking about buprenorphine, which is name brand Suboxone, Subutex, Zubsolv, Bunavail, the new long-term injectable Sublocade, there's a lot of brand names, but buprenorphine is the actual medication. It can be done in a variety of settings. A comprehensive opioid treatment program where the medication is dispensed on site, and there's also on-site counseling and other medical support. That OTP or opioid treatment program is the same modality where methadone can, and the only modality where methadone can be dispensed for treatment for OUD. But buprenorphine and naltrexone can also be given in a physician's office. So your family physician that's treated your family for generations or decades could get a waiver and do the training to prescribe schedules 3 and 4 for opioid use disorder. And the only Schedule 3 or 4 currently approved is buprenorphine, and then naltrexone is not scheduled at all. So if you're just getting a prescription from your primary care physician, that's not what we're talking about as comprehensive treatment. Now, that doesn't mean that getting it from your primary care physician is a bad approach. It just means that we need to make sure in that case that you have access to these things and that you know where you can also receive counseling and peer support, mutual aid recovery support groups. For some people, that means a 12-step group. But it's more than just the medication, okay? And so we're going to transition a little bit here now, and we're going to talk about why MAT. And so we really want to look at some of the science behind medication-assisted treatment for opioid use disorders. And so I'm not going to take you into a in-depth college-style lecture, but just want to make sure we have some of the basics. And so we are going to be talking about some complex stuff, but we're going to try to break it down in a way that it's understandable so that you can not only meet our learning objectives, but so you can truly understand, not just be able to explain it to others, but really internally understand what we're talking about and where the evidence comes from and why it works. This is the part I think a lot of people, even that support medication-assisted treatment, don't really understand the science. They know that some of the medications, methadone and buprenorphine specifically, will reduce withdrawal symptoms or eliminate them, will reduce drug cravings. Beyond that, don't know a whole lot more about how they act on the brain and really how they even allow the brain to heal. They may know about naltrexone, which again is a totally different MAT approach, that it may block the euphoria from opioids if used. And that in some instances it has also been alleged to help with reduced opioid craving. We definitely have definitive evidence that naltrexone helps with alcohol cravings, but with opioid cravings. But why? How does that work and what's going on in the brain? And so like many chronic medical conditions, we could treat addiction before we understood it. So we have to go back a little bit now in history and kind of consider drug policy that also has led us to where we are today. So in the early 1900s, Congress passed a law called the Harrison Narcotics Act. And the Harrison Narcotics Act prohibited the prescribing of a substance to a patient that was addicted to it. And so in the early 1900s, the late 1800s, we had a lot of individuals in the United States that dealt with what today we would call an opioid use disorder. And they were primarily two groups of people: veterans, especially Civil War veterans, that had become dependent on morphine that was administered on the battlefield. And now, knowing more about what we know about science, there's a lot of theory that it was also a form of self-medication for some of the combat-related trauma. But war veterans, and then also it was, other than war veterans, it was middle to upper middle class white women. And there was actually, many people don't know, morphine clinics in the early 1900s. Doctors wrote morphine as a maintenance treatment. Diacetylmorphine, or AKA heroin, was also prescribed to some people. Heroin was in a lot of different syrups and elixirs that people could order out of catalogs. In fact, a lot of people don't know that heroin was actually the original brand name of diacetylmorphine, and that heroin was patented as a brand by the Bayer Aspirin, today's Bayer Aspirin company. Bayer is who named diacetylmorphine heroin, and it was a medication. And so we tried to treat addiction in the medical community in the late 1800s and early 1900s, and people with opioid use disorder back then were primarily seen, they were looked at with sympathy. And most of society approached them as though they should have access to treatment and that a physician should be able to try to help them. Then a lot of things happen, and this, I could do an entire presentation just on the drug policy and all the sociological things involved there, but the face of the person who was addicted or dependent upon opioids and other substances began to change as time moved on. And so you get into the early 1900s, and we start seeing different substances start to become criminalized. And so what the Harrison Narcotics Act did was it took all the legitimate, or what was then seen as legitimate medical treatment, it was legally prescribing substances to try to help people, and made that illegal. And so later that law ended up being challenged, and a lot of medical groups and physicians sided with the challenge to the law. It ultimately went to the Supreme Court, and the Supreme Court's interpretation of the Harrison Narcotics Act was such that if you prescribe an opioid to someone with an opioid addiction, you're violating the law. And so then that gave what was then the Bureau of Narcotics was in the Treasury Department, which was really the precursor to our modern DEA, or Drug Enforcement Administration. Harry Anslinger was the head of this Bureau of Narcotics at the time, and he really went hot and heavy after physicians that were prescribing. They were thrown in jail, and they really cracked down. And so from about 1917, 1919, around in there, all the way until the late 60s, early 70s, there was no medical treatment for substance use disorders, not just opioid use disorder. And it was during that same period of time, for any of you on this phone that know some of your history around Alcoholics Anonymous and the 12-step fellowships, it was during that vacuum of medical treatment, when there weren't any, that Dr. Bill and the mutual aid recovery support groups began to develop, and then some treatment, not using medications because that was illegal, began to be developed around that model. So all that kind of developed in a time when there was no legitimate medical treatment. In the 60s, the early to mid-60s, we had the American Bar Association, the American Medical Association, and other prominent national groups, because of heroin problems, primarily in some of the larger cities, especially New York, that called for study and the possibility of a medical intervention for opioid use disorder specifically. And so long story short, that fast-forwarded and led to two physicians known as Dr. Vincent Dole and Marie Niswander, and their research assistant, Dr. Mary Jean Creek, who is still alive and works at the Rockefeller Center in New York, Rockefeller University, in New York. And they did all the studies and trials and ended up publishing a paper called about the treatment of a heroin addict. And they developed, and in their study, they came across this medication, a long-acting opioid, now we know it as methadone, that at the time was a more recent spoil of war, okay? So it was, the formulation of methadone was come up with by German scientists during World War II, when the Allied forces had really cut Germany off, right? So they had cut Germany off. They couldn't get the raw opium they needed to do morphine, to formulate morphine and do other things for their soldiers. And so German scientists came up with an opioid that could be used for the treatment of pain. And there's all kinds of conspiracy theories around that as well, but nonetheless, methadone was a spoil of war, and we didn't know a whole lot about it. But what they discovered is that it was long-acting, that the person could take it once a day if it was an adequate dose, and that they could take the same dose over a long period of time, so that tolerance, the need of more over time, was not present. And it was affected by oral administration, where a lot of other opioids like morphine are best effective through intravenous administration. That's why in the hospital you'll get it through your IV. And they realized that it normalized people, that they started thinking normally and dreaming again and were able to start functioning again. And so we could treat it, and we knew that this medication in these early trials worked, but we didn't really know why. And so now we know why the medications work, okay? And more importantly, we know that substance use disorders are medical conditions and treatable diseases. These are chronic diseases. Opioid use disorder is a chronic disease and metabolic disorder. And when we think about that, and we think about how we treat any other chronic disease, take substance use disorders out of your mind, take opioid use disorder out of your mind, how do we approach the treatment of any other chronic disease? Is it a one and done, a 30-day program and then you're good, or, if someone has another chronic disease that goes into remission, something extreme like cancer, they're going to have ongoing follow-ups and check-ins and be diligent about the fact that it is a potentially relapsing disease. Even blood pressure, people through dietary change and medication and lifestyle change, some may be able to even not need medication, but they're still going to check their blood pressure at the grocery store. They're still going to be checking in with their primary care physician, whether they're on medication or not. And so again, when we talk about a chronic disease, we're talking about ongoing interventions and ongoing follow-up. So to be more specific, we know that substance use disorders or addiction, it's a chronic disease of the brain. So what's going on organically is happening in the brain, but it is expressed through compulsive behavior within a social context. And so it's really the expression of a substance use disorder and opioid use disorder that's made it so difficult for people to understand and to accept that it's a disease. They can't see what's going on in the brain, although we are going to look at least one brain scan today. So you're going to actually see inside a brain a little later. But it's expressed through compulsive behavior. The changes that happen in the brain are expressed through behavior within a social context. It's a biopsychosocial disorder, and many people have probably heard about that and heard that term, biopsychosocial. That's why we do a biopsychosocial assessment of a patient as they come into treatment or as they're being assessed for appropriate treatment. And so a biopsychosocial disorder, there are things biologically going on in the brain, biological changes, psychological component, and ultimately it's expressed within a social context. It can be reinforced by a social context, and most people don't tend to develop a substance use disorder in isolation. And so we have to recognize that about substance use disorders. And so some of the reasons why it's so hard for so many people to believe opioid use disorder is a disease, like any other disease, because we hear a lot of people say, even in the rooms as someone in long-term recovery, right? Even in the rooms we hear people talk about that my disease, this disease, but then you can't believe it's a chronic disease or purport to believe it's a chronic disease out of one side of your mouth, and then out of the other side of your mouth reject its legitimate medical treatment. Or that would be, just like someone, unless you reject, I suppose, the medical treatment for all other diseases. But if you truly believe that we're dealing with a chronic metabolic disorder and a chronic disease of the brain, then you're obligated to accept its treatment, or you don't really believe it's a disease. And so some of the reason it's so hard for people, even in the face of the science, is that its appearance. It doesn't appear to be a disease. You don't see it. You don't see the sickness. It's expressed by behavior. So what you do see from the disease is the compulsions and the behavior. So a lot of people don't realize that the signals, the human brain that is dependent on opioids sends to the body that drives behavior when the brain goes into opioid withdrawals are nearly identical to the same chemical process, the same signal sent by the brain if a human is starving to death, literally starving, not just, oh, I'm hungry, I'm starving. Literally, if you were starving to the point of survival, you and your children, it was necessary for survival that you find food. Most human beings, and that's something that most of us in America can't even comprehend, you will do most anything to survive, including stealing a sandwich from the 7-Eleven or whatever it takes. And it's those same signals the brain sends when someone's in opioid withdrawals. Literally, it becomes to the person with an opioid use disorder necessary for survival to avoid withdrawals, to continue opioid use. The brain sends signals so that the brain will die if it doesn't take opioids. We know it won't, but that's the power of the chemical interactions and the signals that drive the behavior. So you steal your grandmother's checkbook. So you rob the Walgreens. So you do all these things. You engage in risky sexual behavior for pay or for the substance that will make you well, because it's you feel that it's survival, but it's expressed through behavior. Also, it's largely misunderstood. A big part of the drug policy piece that we're not going to have time to go into today is how much of our drug policy in the United States is rooted in racism, is rooted in prejudice. A lot of the laws that ended up prohibiting substances or criminalizing people that had substance use disorders were because of their race. Like I said, in the late 1800s and early 1900s, when the face of the individual with opioid use disorder were war vets and middle to upper middle class white women, we treated it with compassion. We treated them with sympathy. But what happened when the race or the color of the person dealing with a substance use disorder changed is people moved out, as Caucasian Americans moved out of the urban areas and started settling in suburban areas. And through a lot of other reasons, again, this is the whole presentation, we began to ghettoize, if you will, through redlining, was the practice, redlining certain communities, especially communities of color in urban areas. Substance use began to proliferate within those communities, and as the face got darker, the entire societal approach to substance use disorders changed from compassionate views to lock them up and throw away the key. So we can't discount, as uncomfortable as it is, that we have to understand our own history in the United States of prejudice and racism as it impacts our drug policy, and ultimately how that history impacts the way we have viewed and responded to opioid use disorder over the time. Victims are criminalized. Like I said, with any other chronic disease, we wouldn't lock them up and throw away the key. We would try to seek medical treatment. Now, if another disorder, especially some other mental disorders, were manifest in behavior such that it caused violation of the law, the criminal justice system, of course, could and should be involved in some ways, but we wouldn't approach it only through the criminal justice system. It makes no sense to approach what is a public health crisis with the criminal justice system alone, although they can be big partners in it. Victims are dehumanized, right? We hear people say, oh, that's just a junkie, just old junkie. Oh, she's an addict, you know, those addicts. We dehumanize people. And it's important to remember, too, as science has come a long way, that it was just a little over 100 years ago that we thought psychosis was possession by demons. And now for some people that debate might still be ongoing, and I'm not questioning the spiritual realm. But what I'm saying is, if someone had a psychotic break, we now, in cases where it's truly a psychotic break, that is, or people that have certain mental disorders, we now know what's going on in the brain and why those are caused and how we can stabilize them. So we have to realize that science has come a long way, but we still don't know everything. And so we have to, as professionals and even just as good citizens in a country that's facing an opioid crisis, we have to constantly be open to learn. I try to, with the information and evidence that we are talking about and that I'm sharing with you today, we have to constantly be open. And I have to even be open to the fact that everything I'm sharing today with future research will be built upon, and that we may understand something better and more differently. So keep in mind we don't know everything, and I think that's part of the reason it's hard for some people to understand as well. So what we know is that opioid use disorder is complex. It is not simple. It's complex. There's a lot of stuff going on in the brain. There's typically a lot of stuff going on in the individual's environment. Psychologically, we know that a lot of individuals with substance use disorder have trauma, and that's why there's such a focus now by SAMHSA and others on trauma-informed care, address some of the root causes that maybe led to the development of the substance use disorder. So it's complex. There's a lot of stuff going on. It's not straightforward, and it manifests differently and develops differently from individual to individual. But we do know when we're talking about who is vulnerable to develop an opioid use disorder, and this is critical in its treatment, is that your biology, the bio part of biopsychosocial, is an important part, your genetic makeup, that we're just on the very top tip of the iceberg on research around genetics and so on. And at this time, it is important to note for any of the my psychopathology professors that may be on the call that the DSM does not currently weight family history or genes or any of that in the diagnostic criteria. And that's true, but that doesn't mean that we don't have evidence that there are certain patterns within families. And we're on the tip of that iceberg, but what we do know is that we do see substance use disorders that tend to run in families from different generations, especially when we look at alcohol use disorder and opioid use disorder that have similar neural pathways in the brain and similar parts of the brain involved. We definitely start to see patterns of those two, especially within families when we're talking about opioid use disorder. So you didn't get to choose your parents or your ancestors or your genetic makeup. And so that's why someone like my sister, same mother, same father, same genetic heritage, has never struggled with substance use disorders at all. But myself, I developed a chronic substance use disorder that was really life-altering, could have been life-ending. And it goes back to, that's just one thing that makes us vulnerable, but there's a lot else going on because your environment plays a role too, okay? Do you have all the support you need? Have you experienced any trauma that hasn't been treated? Do you have good familial relationships? What stressors are in your environment? And so what we know is that the biology and the environment are constantly interacting, and that's what really makes someone vulnerable to the development of this. And so we can't hang it all on biology and genes, and that's why we can't hang its treatment all on medication. The medication is one part, but if we're not addressing the environment and the biology and what's going on, it not only tells us who's vulnerable, it shows us how we can have an effective treatment. So again, a biopsychosocial disorder requires a biopsychosocial approach. And if we have all the psychosocial interventions and clinical interventions in the world, but we don't address what's going on in the brain's biology, then it's going to do little for us to treat the full disorder. And that's why you see when you don't use medication-assisted treatment, the numbers for relapse are up in the 90% range typically. And that drops drastically to down between 10 and 30% depending on medication and length of time of treatment for MAT, because you're leaving a third biopsychosocial. If you leave the bio off and don't address that at all, you're leaving out a third of the disease. So typically I would ask, if I use this slide in a presentation, I ask people who notice this, right? So I'm sure people are out there raising their hands. That was what we knew as our brain drugs. I believe this was the 90s. It was the Partnership for Drug-Free America, which is actually a great organization that continues to do a lot of good work and, in fact, has put out some good information about MAT and opioid use disorder in more recent years. But that was how we thought of things, right? They fried their brain. And so science has really come a long way in helping us understand how drugs of abuse affect the brain. And so we no longer have to think of our brain as that, but this is your brain on drugs today. And so this is the only of all the different brain scans spanning decades. I'm only going to show you one, I promise. And what I want you to pay attention to, I'm not sure, you probably can't see my cursor of my mouse, but you can see the white arrows on each of these three brains. And so let me explain what we're looking at here to give you insight into what we're talking about. We're looking here at the elevated glucose metabolism. And so glucose is your brain's food, right? So the way your brain metabolizes glucose can tell us different things. And so that's what we're looking at here. So the first brain is your control. The middle one is opiate dependence on agonist therapy. So this would be your methadone or buprenorphine brain. The brain in this particular study from the Mount Sinai Journal of Medicine was methadone maintained, but be very similar for buprenorphine. And then your third brain all the way to the right is opiate dependent, so someone that has an opioid use disorder in sustained remission. So that's an abstinence-based brain, if you will, or no medication-assisted treatment, 90 meetings in 90 days approach. And so what I want you to look at is the red, especially up towards the frontal part of the brain. And you'll see the control versus the middle brain. There is a little bit more red in the middle and the control. But then if you look all the way to the right at all the much larger presence of the red there in the frontal parts of the brain especially, what this tells us, and again, this is just, it is what it is, it's the evidence, is that the brain in the middle, or the medication-assisted treatment brain, if you will, is closer to normal, is quite frankly healthier than its counterpart that has been able to sustain remission, but without the use of a medication. So as rare as the brain on the right side is, and there are some that have achieved recovery that way. My own clinical supervisor, in fact, in recovery from a heroin addiction. She has been for 20 years, and she didn't use medication. But what this tells us is the brain on the right, that's a brain in stress. That's a brain on the verge of relapse. And so this really shows us how we can see into the brain and how medication-assisted treatment with methadone or buprenorphine specifically, and again, we're going to get to naltrexone later, not only ward off the withdrawal symptoms and cravings and allow someone to live a normal life, but they actually facilitate the healing of the brain. And so what happens to the brain, in the 70s, endorphins were discovered, which are the brain's own opiate system, okay? So we have endogenous or natural opioids in our brain. Endorphins are how we reference them, and there are different types of endorphins that are used in a lot of different processes, and they're important in maintaining the body's homeostasis, or keeping the body adjusted to normal. So the brain and the body are constantly releasing chemicals, metabolizing things out to keep the body internal equilibrium balanced through adjusting physiological processes. And so endorphins are also involved in the modulation of many of the brain's systems involved in behavior. One of the other things the brain's natural opioid system does is the natural control of pain. If you break your toe and it starts throbbing, it will stop throbbing as much very quickly. And then, down the road, it's going to hurt a lot worse because your brain's natural endorphins are at play. So if you think of it like a lock and a key, the endorphins or which are also neurotransmitters, they're chemicals, right? They're a morphine-like molecule that all of our brains have. Everyone on this webinar is opioid dependent. Yes, you are. You're dependent on your natural opioids, the natural opioid peptide system in your brain. And then think of the lock or like these receptor sites, and that's what we talked about early on at the very beginning of the webinar. The endorphins go into the lock, they fit perfectly, and when they turn the lock, it causes the release of other things like dopamine, and it causes a response. And so these endorphins are the key, and the receptors are the lock, one way to think of it that way. And the key goes perfectly into the lock. You could also think of it like, those rows of condos or homes where all of them look exactly the same on the front with the garage and they all look identical. If you think that, the garage door opens and the car goes in and the garage door shuts, that's, kind of the same thing too. And then there are partial opioids. So maybe the car goes halfway into the garage, but the garage door is only halfway open and can't get all the way in. And then you've got naltrexone, which we're going to talk about a little later. The garage door is shut. That car is not getting in at all. But the biological component of this is that this is a metabolic disorder of the brain. And what happens over time is that as you continually use outside opioids, like heroin or prescription pain relievers, especially, and it changes based on route of administration, the brain sees that you're introducing all these outside keys, if you will, and it says, okay, well, I don't need to make as many keys. And so you will see a lowering of the natural production of endorphins. In some people, that production is completely eliminated. And so it damages that natural part of the brain. On the other side, you have your receptor sites. And so, as you continually use more and more outside opioids or exogenous opioids, if you want to use the scientific term, the brain sees that you've got more and more keys and more keys, but there's not enough locks to fit all the keys. And so the brain will literally, as a very plastic organ, make more receptor sites. It will lay down more receptor sites to accommodate all these different keys. But then with short-acting opioids, you go in and out of withdrawals, and then you go into withdrawals, and all the keys go away, and then the brain says, oh, wait, I've got too many receptors. Now I need to take them up, and the brain will start initiating the process of actually taking up or paring down some of the receptor sites, but then you use again. And so you go up and down, and the brain's saying, okay, I need more receptors. No, I don't need enough. And what happens through all that disruption and that imbalance of the highs and the lows of short-acting opioid use is you end up damaging this natural opioid system in the brain. Not only is the production of endorphins affected, and that in many individuals it is the natural endorphins that are produced are greatly lowered or even eliminated completely, and that's also known as endorphin deficiency syndrome. But on the other side, it's not just because of lower endorphins. The actual receptor sites or the locks themselves can become damaged. The literature refers to it as though they become deranged because of the highs and lows of the short-acting opioids. And so the long-term use of these can damage this endorphin system, and the body can not even maintain basic functions like body temperature. These chemicals, neurotransmitters, are involved in the regulation of so many things. And so the endorphin's ability to regulate some important functions are also damaged, like immune and hormone function. And so there's a lot of things that can happen. And so we're still unraveling it. It's a really complex medical condition. Like many other chronic conditions, it takes time to understand it. Advances in neurosciences have helped move things forward. And now we know why methadone and buprenorphine work. And the way those two work, and again, we're going to get to naltrexone after our break here in just a few minutes, is that we're talking about these natural endorphins in the brain that are used. They're important for natural pain control. They're used in a variety of things. They're released during both male and female orgasms, so that was a big motivator for propagation of the species and our biological development. And so, you know, back in the day for survival, if you broke your toe on a tree stump while a tiger was chasing you in the jungle, you're not going to feel the toe, because if you stop and feel the toe, the tiger's going to eat you, right? And so this natural endorphin system masks that pain. Now, when you're safe later and all these different, the adrenaline and the endorphins and the dopamine and all that level back out and your body goes back to homeostasis, the toe's going to hurt like heck. So all this is part of our natural processes to live a normal, healthy life, and opioid use disrupts that. And so as we were talking, the natural endorphins, or these natural opioids that are important in all of us living a quality life, are often diminished with someone in long-acting opioid use disorder. So methadone and buprenorphine are long-acting synthetic opioids. And what they do is they don't have the spikes, the highs and the lows of these short-acting opioids. So when we introduce a long-acting medication like methadone and buprenorphine, it has a gradual onset of action. It slowly builds in the system, and then it holds for a long period of time and slowly releases until you take your dose the next day, and you kind of stay within the normal range. You don't get up into the high highs, but you also don't get down into withdrawals. And so what it does is it actually mimics the brain's own natural endorphins. And so when we think of medication-assisted treatment with methadone and buprenorphine, Suboxone Subutex, it's really an endorphin replacement therapy. When we talk about opioid replacement therapy or opioid substitution therapy, a lot of people don't like that terminology because they say, oh, that emphasizes that you're trading one drug for another, or it perpetuates that misunderstanding. But what those are referencing is not that you're substituting an illicit, but that you're replacing the brain's own natural endorphins with a synthetic man-made version, just like we do in many other medical treatments. With diabetes, we have a pancreas that is no longer producing insulin, so we give a synthetic version of insulin so the person can live a normal life. And so similarly with methadone and buprenorphine. And then over time, because you don't have those spikes and those withdrawals that damage the system, the receptor sites that we were talking about becoming deranged, they can actually heal, and that's why we need longer-term maintenance. They can heal while you're in medication-assisted treatment. And then many patients then will be able to slowly reduce the dose after a period of, the National Institute on Drug Abuse says a minimum of 1 to 2 years. Other people need it much, much longer. It has to be individualized, again, like any other medical treatment. But you slowly reduce the dosage a little bit at a time, and then the brain's natural system, the hope is that it would stimulate the production of those natural endorphins again. So you can't come down faster than the brain can replace these outside opioids or synthetic endorphins with its natural, and slowly, slowly taper, and the brain exercises, if you will, and begins to replace what the buprenorphine or the methadone was doing with natural endorphins again. And so you go slowly over time. So it's during the maintenance phase that the receptor sites and all those processes that were affected can begin to heal, and then for a slow, steady, and proper taper after a period of maintenance that allows the stimulation and production of natural endorphins to take over again. But it's important to remember that some people's opioid ligand system may never be able to produce normal levels of endorphins again. So some people may be able to taper down part way or halfway or 2/3 of the way, and then get to a point where, if quality of life is our measure, they're not able to go all the way. Other people's brains may never be able to produce natural levels of endorphins again, and still yet there's some research now indicating that some people maybe never truly had a normal level of these natural endogenous opioids. And so that's important to remember too. And so we know why these medications work and that they're not substitute drugs, because what these medications do is mimic the natural processes of a chemical and system that becomes damaged. There's nothing similar to the highs and lows of the abuse of short-acting opioids like heroin, morphine, oxycodone, and what that does to the brain, and the way methadone and buprenorphine mimic the natural opioids we all have. They're not substitute drugs, but they are medications that normalize a system that has been damaged by drug use. So when they're prescribed or administered under monitored, controlled conditions, they're safe and effective when they're used as directed. They're administered orally or sublingually under the tongue, and now there's a Budavel, one name brand version of buprenorphine naloxone that's buccal. It's a buccal, it goes in the cheek in specified doses, and their effects differ from those of heroin or other abused opioids. Like we talked about, there is no rush like from heroin when it's snorted, injected, or smoked, and this brief euphoria and then a crash. That rush and the crash go away, and with that, the intense cravings and that cycle of euphoria, crash, and craving, which goes on multiple times a day, is what not only results in the severe behavioral disruption and the constant need to seek and obtain it, but it's also what damages these natural systems of the brain that agonist or partial agonist treatment can allow to heal and normalize. And so these gradual onsets of action that we discussed are what really make these medications work. And so that the patients in MAT do not experience the physiological or behavioral abnormalities from the rapid fluctuations in drug levels associated with short-acting opioid use. And so it helps to stabilize individuals. It allows the treatment of their medical, psychological, and other problems so they can once again contribute effectively as members of society. And if you think about these medications, they normalize a dysfunctional brain. Dr. Herman Joseph, who was another research assistant to Drs. Dole and Niswander that I talked about earlier, the pioneers in medication-assisted treatment, he just passed away actually about a month ago. I had the privilege to present with him at a national conference one time, but he always stressed methadone and buprenorphine as normalizers. They normalize a dysfunctional brain and allow it to heal. And so a couple of, again, I told you I'd hit you with a bunch of the different studies, but in a comprehensive literature review, so Psychiatric Services in 2013 published a literature review where the authors looked at all the literature on methadone. Overall, there is a high level of evidence for the effectiveness of methadone maintenance treatment and improving treatment retention and decreasing illicit opioid use. That's the summary of all the research and the studies spanning half century. The year later, they did the same thing with buprenorphine. Keeping in mind, we've got much less data. We've not been doing it as long, but nearly 20 years now, and they concluded that overall a high level of evidence was found for the effectiveness of buprenorphine maintenance treatment in improving treatment retention and decreasing illicit opioid use. And so medication-assisted treatment for opioid use disorder with methadone or buprenorphine is the textbook definition of an evidence-based practice, study after study after study. And so, again, real quick, we want to look at naltrexone. So this is different. So it is an antagonist. It was created in '65, and it was originally approved for use in '84. So a lot of people don't realize this, but it was oral form until very recently when an extended-release injectable form was made, which is brand name patented as Vivitrol. And so what naltrexone is it's an opioid antagonist. And so what that means is it is a blocker. It seals off those opioid receptors. It won't let a key get in the lock. It won't let a car get in the garage door. The garage door is shut. And so it does not mimic the natural endorphins like the other two do. And so it's a different approach. It is a blocker. And so it can be used in a variety of settings, but it was used since the 80s as an oral form with little effectiveness due to poor compliance. So someone could just not take their pill. They would usually get it from a psychiatrist or a physician, and all they had to do was not take their naltrexone that day, and then they could get high that night. And so other than in a very, very, very small subset of highly motivated patients with a lot of support, we just didn't see, the compliance was so poor, we didn't really even have meaningful data around its use. And so it's the injectable form that was recently approved. And again, it's an antagonist, and so it does not mimic the natural opioids and may also block the brain's natural opioids. So if you have someone that's got a predisposition to depression or pain or anxiety, we have to keep in mind not only will it block the outside opioids, it could also block the brain's natural opioids. And so the individual must be fully detoxed from all opioids before starting for 7 to 10 days, maybe even longer, buprenorphine or methadone. It could be a relapse prevention tool after a taper with methadone or buprenorphine if someone wanted to transition to naltrexone or Vivitrol. The Vivitrol injection is a 30-day injection, so you would always start with the oral naltrexone to do a trial and make sure there's no reactions. And again, it's often appropriate for a small specialized population. So individuals recently released from penal institutions, they are completely detoxed off of everything. Vivitrol could be an appropriate option there. So it's a different approach with naltrexone, and it doesn't do all the same things, but it's still, again, we need to have all the tools available in our toolbox, but we can't assume it's just not biologically or pharmacologically true that it's going to interact with the brain and allow its healing the same way as buprenorphine or methadone do. But it's a very appropriate intervention for some people in different settings in specific instances. Okay, with that, we're going to take and like I said, it can be used after a medically supervised withdrawal. We're going to take a quick break, and I'm going to turn it back over for a minute for that, and then we'll come back together and we'll be done then a little before 2 o'clock.
We be back. We're going to take a 5-minute break at 1:23. We'll be back here to hear Zach again and to wrap up this webinar. Thank you. welcome back. Zach, if you're ready, I would like to turn the presentation back over to you.
Okay, I'm ready. Okay, so real quick, there was a couple questions I'm going to address and summarize in a minute. One of them was, of all these studies, how many percentage-wise have been financed by pharmaceutical companies? That's a great question. Of the citations, and you'll have the bibliography at the end, and this will also be emailed out to you, I have not cited any pharmaceutical-backed or finance studies, but there are a lot out there, especially around some of the newer name brand formulations. Alkermes, that owns the patent on Vivitrol that we were just talking about, has funded a lot of studies. You also need to look for if anyone, even if they didn't fund it, are the researchers themselves, do they have ties to the pharmaceutical company? So it doesn't mean that it's not that it discredits the study, but it is something to keep in mind. So that's a great question. So the ones I've cited, none. And then there was another question that says, why can't you use data newer than 2017 and 2013? I guess that was one specific slide maybe. Towards the beginning, we did have citations in 2019, for example. But what matters with this and in other things, if you're talking about technology or something, certainly within 2 years it's no longer credible. But the topic at hand, especially when it comes to those literature reviews, there's nothing more recent that either gives us a clearer picture of those things, and there's nothing more recent that contradicts it. And so what I want to give you is the best, most current available evidence. And if on a particular topic, the best, most current available that we have from an objective source is 2017 or even 2013, then that's what I'm going to give you. And so that's where those came from. Again, we have, and a lot of the points I'm trying to make, I think, as I reiterated and have said a couple times already, is that we have so many studies spanning 50 years that I'm just pulling out a representative sample. And that's why I wanted to give you the 2 literature reviews that specifically looked at all of the literature. But we did have some citations up into 2019, as recently as this year, that were in there, and we had some that were even older than 2013. So again, we're trying to give you the best picture with the best evidence we've got. So thanks for those good questions. Okay, and so real quick, we want to talk about language as we're combating stigma, the meat of the science we've gotten through. But what is recovery? And it's important to note that there's no clinical definition of the word recovery, and that this is a patient term, a client term, a consumer term, or a peer term that has varying meanings and applications. Now, SAMHSA did develop a working definition of recovery, and they characterize it as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And so that gives us a good summary. Some patients in medication-assisted treatment, because of the stigma is so great, are often surprised they could be in recovery when we look at that working definition. And it's important for us to remember that an individual's choice of treatment, or the treatment that's recommended by their primary care physician or other practitioner, their clinical social worker, that has nothing to do with recovery. Methadone or buprenorphine can help foster a life in recovery. Naltrexone and Vivitrol can help sustain a life in recovery when we look at that. And so what matters is someone's life and their quality of life, not whether or not they happen to take a legitimate, legal, and effective medication under a physician's direction twice a day. It just doesn't matter. It's a process of change through which they improve their health and wellness, live a self-directed life, and strive to reach their full potential. It has nothing to do with whether or not they take a medication, just like it doesn't have anything to do with recovery from any other disease. Your blood pressure can be in recovery. That may include a medication or it may not. Again, so do we believe this is a disease or not? So the World Health Organization, specifically talking about this stigma that surrounds substance use disorders in general, says the stigma associated with substance use and dependence can prevent individuals from seeking treatment. and can prevent adequate policies regarding prevention and treatment from being implemented. The shame and the stigma and the unwillingness to seek treatment, it can literally be deadly. Dr. Herman Joseph, the gentleman I referred to earlier that was alongside the original pioneers of MAT, that just passed away within the last month, he specifically was talking about methadone here because it was the oldest, and so it's become the most misunderstood and the most stigmatized. He said, no other medication in the history of modern medicine has been so unjustly maligned. The stigma that methadone patients feel is a real phenomenon, and in comparison with other social stigmas, appears to be entrenched in the collective social consciousness of the country at every level of society. That's a huge thing we have to overcome. And let me interject that I am not an apologist for what often passes for medication-assisted treatment. I recognize, and I think anyone with credibility has to recognize that, like other modalities of healthcare, there are bad players in this field. We can't ignore that, and we can't stick our heads in the sand. I think we can call it out when we see it. Some of that's the delivery system in your own state of Florida. Some of the opioid treatment programs that can dispense all three, including methadone, have become huge. And part of that's because of the regulatory structure and the difficulty of getting licensed, and so there's only so many with such a huge demand, and so that leads to administrative issues that can be difficult to overcome. The good news is Florida has just opened up and is approving a lot more licenses to come in, and so hopefully we'll have more reasonably sized opioid treatment programs in Florida that offer the different medications and aren't no longer offer just that. I like it. We had another comment just now, or question. If we use the disease concept instead of recovery, why not use remission? Instead of relapse, let's use recurrence. I love that. And that's a great, when we're talking about language, those are the things we need to talk about. I love that. Remission, and in the DSM, I think it's important to realize that if someone previously met criteria for opioid use disorder, because it's a chronic disease, they will have that diagnosis and the disorder for the long term. But the specifiers are in early remission or in sustained remission. And so when we actually look at the DSM, Tom, that is the language they're using. I like that you point that out, and that's good. Recovery is more on the peer side, I think, for people that are in remission, if you will. But as clinicians or as treatment professionals, certainly you make good point. Remission, recurrence, those are, if we're talking about any other disease. The stigma for these patients is so painful that it can be as great as the stigma of being an active heroin user. Think about that. The stigma of accepting the most evidence-based treatment for your disease, doing the best thing the science shows you can do, is so stigmatized that it can be just as painful as the stigma associated with active heroin use. Many patients feel that they must remain silent about the treatment that has saved their life and the accomplishments that they've made during treatment. We hear people told, you're not clean because you take a proven medication. Although many rooms and 12-step meetings are very different since they're all autonomous, oftentimes we hear our MAT patients not told that they can't speak at 12-step meetings because they're not clean. And so stigma can actually be one of the largest barriers to recovery for MAT patients. As we think back to what we learned about the brain and how these medications allow the brain to heal and normalize over time, and then other medications like naltrexone can help facilitate the continuance of your state of remission, if we're using clinical language. And then they have a sponsor or someone that's not a medical professional, not a clinician, tell them they're not clean and that they need to jump off their treatment medication. And we know that upwards of 90%, greater than 90% of people who do that relapse to illicit opioid use. So again, that stigma, that misinformation, that can be one of the largest barriers to sustained recovery for many of these patients. But all the while, the evidence is solid. Zarkin, this is a particular study from 2005, and because there's not been another study conducted similarly since, that suggests from developing a lifetime simulation model analysis that every dollar invested, I would love to see this now with buprenorphine now that we've had 20 years if someone would redo it, but at the time, every dollar invested in methadone treatment yields $38 in economic benefits to society, mostly in reducing incarceration costs, but with less crime and greater employment. $38 for every dollar put in, and in so many cases, society's not even putting the dollar in. A lot of times patients are paying for these treatments out of their own pockets, but then society yields the results. Another study showed that methadone treatment is more cost-effective than many widely used medical therapies and should be included in formularies of health plans. But stigma, misinformation, and a lack of understanding medication-assisted treatment has led to drug courts and other criminal justice systems to discriminate against a proven effective approach, further discouraging individuals suffering from opioid use disorder from seeking evidence-based treatment. And so, again, it takes time, just like with SAMHSA and the data around the opioid crisis that we started with, it takes us years before we can actually gather and then compound and then analyze data. And so we won't have 2019 data for several years at this point. Now that we have buprenorphine, again, DATA 2000, the Drug Addiction Treatment Act of 2000 is what approved buprenorphine in a prescribing setting. We've been doing buprenorphine enough to have meaningful data for about going on 20 years. The problem there is where it's so often prescribed, it's not tracked. Medications are tracked in opioid treatment programs. And so a lot of people wonder, we don't even have a lot of data around the DATA 2000 practices. And so that makes gathering some of this or analyzing it going forward more difficult. But nonetheless, it'll be interesting to see as time goes on. We know that in terms of outcomes and effectiveness and that buprenorphine is hand-in-hand, neck-and-neck with methadone when it's used in part of a comprehensive treatment environment, at least for those, again, that don't have really high tolerances or really long addiction histories. We do see a subset, because buprenorphine is a partial agonist, that just will need a full agonist to completely stabilize. And but buprenorphine is also typically more expensive, can be cost prohibitive, and so again, those are all administrative issues that have to be overcome. But again, if we're talking about the disease model and any other modality of healthcare, any other treatment, physicians tend to start with a medication that has the best safety profile, the fewest, the lower opportunity for abuse, and so on. And then if that doesn't work, we go from there. So we need to consider that maybe if we work towards a system where it's not cost prohibitive, that people try buprenorphine, and then those from whom it's not effective move to methadone. But there's a lot of exciting stuff on the horizon. But judges, probation, and parole officers often have the power to issue orders to a defendant to taper from methadone or buprenorphine without any knowledge of opioid use disorder and contrary to medical advice. In Florida, there's a really exciting stuff going on in your Miami-Dade, the drug court judge down there. She's actually going to be a plenary speaker at our national conference of the American Association for the Treatment of Opioid Dependence this October, which is going to be held in Orlando this year, actually, where she's really, she gets it and is deferring to the medical professionals and has established a buprenorphine, and they don't do methadone, but they've got buprenorphine and naltrexone, Vivitrol, a clinic through the drug court. It's really exciting stuff going on, but often it goes wrong, and we've seen it go wrong, and this, again, is the problem with stigma. And so one example that I want you all just to really understand how deadly and devastating stigma can be when people in positions of authority espouse stigma and are swayed by misinformation. The Nassau County Felony Treatment Court is one example. This was in New York. Did not allow defendants to enroll or remain in methadone or buprenorphine treatment upon threat of incarceration. And I want you to see the potential outcome of such a stigmatized viewpoint. I'm going to let the IT folks have to pull up a short video for us before we move towards wrapping up today.
With the heroin plague tearing through New York suburbs, some of the biggest battles in the war on addiction are fought in the state's drug courts. But the I-Team found some courts are effectively banning an accepted form of addiction treatment. As Chris Glorioso learned, access to methadone may depend on something as arbitrary as a county line.
Robert Lepolsky's attic bedroom looks nearly the way it did 6 months ago, the day he was carried away by medics after ingesting a lethal dose of heroin.
6 months has passed and it doesn't get easier.
Robert's father, Rudolph, says the thing that haunts him most, he believes his son's death was preventable. After years of addiction and scrapes with the law, Robert was off heroin, holding down a good job, and in a methadone recovery program.
He was feeling good, healthy.
But then, Robert was arrested for a drug sale that dated back months before he got clean. He landed in Nassau County's Felony Drug Diversion Court, a court that gives addicts a chance to clear their records and avoid jail. But to participate, Judge Frank Galata told Robert he would have to give up the methadone, a drug he credited for his successful recovery. Without methadone, Robert slid back to heroin, overdosed, and died.
The judicial system failed him because he was still on the methadone. He wouldn't make it, without the drugs.
Judge Galata declined to talk about the Robert Lepolsky case, but in a written statement to the I-Team, he defended his policies on methadone and Suboxone, calling the two addiction medications crutches.
They are crutches, he wrote. They are substitutes for drugs and drug cravings without enabling the participant to actually rid him or herself of the addiction. Valerie Rain is director of New York's drug court system. She says defendants often abuse addiction medicines, and judges do have absolute discretion to deny methadone.
They also continue to see a lot of abuse of these drugs. It's a huge problem.
Galata said it's better for defendants in his court to have abstinence from addiction medicines while they're in a structured environment. But defense lawyers in Nassau County say it's not fair that drug court here effectively bans methadone, but in Queens to the west or Suffolk County to the east, methadone is allowed.
When you have a statute that is applied differently, literally 3 miles apart, that means the legislature has to look in and look at it and reevaluate and make a determination. We need to make this uniform.
Do you think it's fair that some people in New York have access to methadone in drug court and other people effectively don't?
I can't answer that.
Dr. Jeffrey Reynolds runs 2 Long Island addiction clinics. He says heroin is ravaging families in Nassau County, and methadone works for many of his patients.
It's hard to imagine us saying to folks, look, I know there's a medication that potentially works, but you can't have that.
I think it's wrong because people who are, they have addictions, it's not only the addiction, it's a disease.
Last year, the National Association of Drug Court Professionals published best practices that say addicts have significantly better outcomes with methadone, and there should not be a blanket exclusion from drug court just because an addict is on methadone. In his statement, Judge Galata indicated no plans to start allowing methadone. On a few occasions, Galata has allowed addicts to continue using Suboxone while in his court, but only if a doctor says withholding the medication would endanger the addict's health. Tom, back to you. All right, Chris, thank you. If you have something you think the News 4 I-Team should look at,
with any of the medications, or if you think, all right, we're there. So that really shows, and this could be true of any of the medications for any disease, but that when we have non-medical professionals, people that are not clinicians, making treatment decisions, the outcome can be deadly. And this, with a treatment that's been so misunderstood throughout time, and as we continue to have studies and new medication-assisted treatment options and choices, and even the existing medications like buprenorphine, we have different ways. I mentioned earlier there's a new medication called Sublocade, which is a buprenorphine formulation that's long-term, a 30-day. There's probufene, which is a 6-month release, that we really need to have medical professionals driving that. I am happy to report on this case. There was a lot of advocacy by the National Alliance for Medication-Assisted Recovery and the Legal Action Center and others in the face of Mr. LaPole's death in New York, that Governor Andrew Cuomo did sign into law a bill that the legislature passed because of this case you just witnessed, that now requires drug courts in the state of New York to permit individuals to receive all three medications. So it prohibits the requiring of defendants to stop taking prescribed medications like methadone, buprenorphine, or naltrexone, and it just can't do that anymore. And it comes dangerously close if does not arrive at the practicing of medicine without a license. And you hear Collado, he referenced it as a crutch. And so Dr. Dole, who again one of the MAT pioneers, really addressed that notion that methadone was a crutch when he said before his death in '96, and he died not long after this, he responded to this notion that medications are no more than a substitute and a crutch, and he said, well, that seems like a vague charge that has no answer. A crutch is not a bad thing if you have only one leg, yet it's not nearly as good a solution as it would be if you could regrow your missing leg. Since we can't regenerate a leg, why not use the crutch and get about and lead more normal lives? Other people think MAT should only last for a short period of time. Dr. O'Neill, who is a professor in the Department of Pharmacy Practice at South College School of Pharmacy in my home area of Knoxville, Tennessee, said strict discontinuance of opioid maintenance therapy, so buprenorphine, Suboxone, methadone, solely on the basis of duration of treatment is not clinically justifiable at this time. Individualization of treatment for opioid addiction with methadone or buprenorphine by qualified specialists is necessary for many suffering patients in conjunction, again, with counseling, community support, and or behavioral interventions. And so these notions, the state of Maine tried to put a 2-year cap, or did put a 2-year cap on the length of time Medicaid could pay, and the governor at the time was still Paul LePage, who made headlines for a variety of reasons over the years. But he, he said, well, 2 years is long enough. They need to get off that stuff. And again, so strict continuation just based on the duration of time, it's not clinically justifiable. And so again, if it were any other metabolic disorder, how would we react to a treatment that was working for any other illness? Just think about that. You know, my father's got cholesterol. He's on a good medication. He's changing his diet. His cholesterol's normal. He's living a healthy life. Would we look at him and say, okay, now you're doing well. Now the treatment's working. Now stop the treatment. Just think about it. Sometimes people in that situation could slowly step off a medication. Others maybe can't. So how would we react to a treatment that was working for any other illness? How do we think of other maintenance medications for other chronic diseases? How do we speak about other chronic diseases? What language do we use? And we've had some good comments and questions and discussion about that already. You know, the Twinkie police, if someone is diabetic, do we kick them out of treatment if their blood sugar spikes? Do we have strong opinions about other medical treatments for other chronic illnesses? Or do we defer to the medical specialists? So again, if someone has a cancer and they go to one of the leading oncologists that employs interventions that are the most evidence-based available for that particular condition, do we as society that aren't treating the patient, do we have to go into the depths that we have today about how the treatments work, how the brain works, or do we trust the medical specialists? So something to think about. Why is it so different with this? And that's what we're talking about, this inherent stigma that Dr. Joseph earlier talked about is in the collective consciousness of society at every level. Real quick, we just had a question about what about maintenance in a DUI program? I don't know if that means like alcohol, or if you're asking like about alcohol maintenance, or if the use of these medications when driving. Okay, thank you. So that's good. So again, like we talked about, methadone and buprenorphine on stable daily maintenance doses mimic the natural opioid, the natural endorphins in our brain. So they are no more impairing on one's ability to drive or operate heavy machinery than your natural endorphins, natural opioids would be. Now, we do say during stabilization, so during the induction period of treatment, especially with methadone, not as much with buprenorphine, but still there as well. While the patient is detoxing from the illicit opioids and the dosage of the methadone or buprenorphine is being stabilized, there can be some, not euphoria or impairment, but, there can be some cognitive reactions as the dose is stabilized. And so we encourage people, especially in those first week or two, as we adjust the dosage, not to drive. But no, someone that's on a stable daily maintenance dose. The Legal Action Center, which their website is lac.org, they're a not-for-profit group of attorneys out of New York. They got a lot of great resources about psychomotor activity and the methadone and buprenorphine maintained patients. So good question. They normalize the brain. They do not impair the brain. Now, someone that's not opioid tolerant, yeah, you're going to have a problem driving. But, again, these are normalizers that are replacing the natural opioids. The brain is no longer functioning. We really all have a role to play in ending stigma. So this opioid addiction and overdose epidemic demands that we educate ourselves on proven treatment interventions and harm reduction methods. Even if we can't get them to where we say should be, what can we do to reduce the harm to themselves and reduce the harm to society? We must learn about and carry naloxone, I'm coming back to that, to help folks stay alive. And then we must encourage folks to seek truly evidence-based treatment. And remember, what is evidence-based? What does that really mean? Slaying stigma and spreading the truth about this epidemic and its treatments, the proven treatments, will save lives. And I talk about the 10%, and that refers to patients. So as a provider of medication-assisted treatment, as someone whose own recovery is credited to these very interventions, in fact, we have about, just like any other population, about 10% or so, give or take a few percentage, depending on the time, of patients that are not what we would want to put out there as the face of the modality. They are the ones that make headlines. And the 10% of clinics that are not providing treatment and that are just selling methadone and not offering all the medications and not focusing on comprehensive treatment, those are the minority. But 10%, they make 99% of the headlines and contribute to that stigma. So don't allow that 10% to spoil the views of all MAT patients or all MAT programs, because well-run programs are quietly making the community safer, and most people don't even know they're there. And most of our patients are quietly bettering their lives, and people have no idea they're patients. Remember the 90%. And so ending stigma really starts with every one of us, and participating in this webinar today and doing all we can to learn about these diseases and to learn about the truly proven effective medical interventions. That's how we start. And we have to separate ourselves from the stigma from the word methadone with so many of us, or the stigmatizing images that conjure up if you say methadone clinic. When we say Suboxone now is getting similarly stigmatized in some communities, and it only takes one unscrupulous or unethical provider to really start that trend. But to take all those images and all those feelings that we may have or we have heard over the years away and just look to the evidence and look to the science and make a decision there. And so we do have just a few minutes. I want to get you all out on time. But we do have a few minutes for just another question or two. And we can then, and then we'll end on a good note there.
Zach, so one of the questions that has populated is, if we use the disease concept instead of recovery, why not use remission instead of relapse?
Right, so that's a good one. And I touched on that a little bit earlier, but again, I think that's a good point because the DSM does use the concept of in early remission, in sustained remission. Recovery is really more of a consumer or a peer terminology. It is not a clinical term like we discussed with one slide, So as far as treatment professionals, I think it's wise to move in that direction to use treatment terminology like we would for any other disease. So that's a good one.
What about maintenance in a DUI program?
So that was, I think, the one where she was asking about could they drive or not. That's, so again, these stable doses, and that's the LAC.org resource I gave everyone where they have the psychomotor studies of methadone and buprenorphine patients specifically. We know with naltrexone it only blocks, so it's not going to be sedating or euphoric in any way. But yeah, so once they're stabilized, it normalizes the brain. It gives them no problems driving.
Where is the insurance industry regarding that?
Oh, well, now that's a good question. So it's coming around. I think it depends on the setting. So like we touched on briefly, y'all, these MAT, and depending on the medication, can be offered in a variety of settings. So the traditional model has been what's known as the opioid treatment program. Statutorily under SAMHSA, who certifies these programs, are known as opioid treatment programs, or OTPs. Historically, these are the programs that we've known as, quote, methadone clinics. I hate the phraseology methadone clinic because I think it conjures up the stigma, but also methadone's but one medication. And so you're seeing where most opioid treatment programs, like the ones that I started and ultimately have become part of the Baymark Health Services family, offer all of the FDA-approved medications because, so it's really just not accurate. But in that modality, insurance has been most perplexed historically because we offer what's called a bundled service. So whether the patient needs counseling once a month because they're really stable or whether they need it 3 times a week plus group, we bill a bundled weekly or daily rate, and insurance just really wants you to break it down. And so that's been some barrier to OTPs. The program that I started in Chatsworth, Georgia, we were actually the first OTP in Georgia to negotiate a commercial contract in network with Blue Cross Blue Shield. And so it's moving in that direction. The opioid bill, the bipartisan bill that overwhelmingly passed both chambers of Congress and that was signed into law by the president recently, will go a long way because that will allow Medicare reimbursement now for all 3 medications in a variety of different settings, including the comprehensive OTP. And where Medicare goes, commercial insurance tends to follow. So we're definitely headed in the right direction. There's only very few states now where Medicaid doesn't cover MAT. What we're starting to see, though, is that sometimes certain insurances may prefer one over the other or try to push us in. And so, but with the Medicare, the opioid bill, that goes into effect January of next year, 2020. That'll really set the trajectory, I think, for commercial insurance because they tend to follow Medicare as an example. And this opioid bill also for the states will require that their Medicaid programs cover all 3 FDA-approved medications for opioid use disorder as well.
Just a couple more. How would you humanize victims of addiction? And then there's a great viewpoint of looking at MAT as endorphin replacement therapy. What can we do to perpetuate this mindset?
Okay, so those are good. So as far as humanizing, and again, this is subjective, but in my experience, I think it goes back to, and that's why we threw this section in about language, where we ended up having the discussion about remission versus recovery, is that language really does matter because it frames the way we view things. And so part of the way people have been dehumanized is through language, referring to people with substance use disorders as junkies or even addict. And you see that a lot still in mutual aid recovery groups. It drives me nuts as someone in recovery that, to start something with, I'm Zach and I'm an addict. Ugh. I think some of that perpetuates this because it puts the disease first. The fact that I have this disease that is in remission is one small part of me. And so I think people first language, I am an individual with a substance use disorder. And I think so it's going to take time as we change our language and we really start to think about if we believe what most of us say, that this is a disease, then how do we treat any other disease? And so I do think that that language is important. As far as perpetuating these other, really the truth, this notion that at least methadone and buprenorphine are an endorphin replacement therapy. It's a good way to look at it. I think that's important. I think that professionals have an obligation to know. I don't know that we'll ever get to that level of detail with the general public, though we should certainly try. There's been a lot of talk recently. I was on a panel recently with the National Quality Forum in Washington, D.C., where we were putting together, and we're currently going through the peer review process of this MAT guide. And one of the things that we identified, and these were experts from all over the country that were on this panel, is that, really it needs to start too in our medical schools and our schools of social work and counseling. Perhaps I sit on our Georgia IC and RC board, which is kind of like our equivalent to your Florida certification board for alcohol and drug counselors. What do we include some of this knowledge as basic requirements? Should doctors, even if they don't want to specialize in addictionology, have some experience or exposure to this? And so I think it really starts at the top, our nursing schools, our graduate programs of psychology, clinical social work, mental health counseling, our medical schools. I think that's where it starts, because if those folks don't know these basics and how these medications really work and allow the brain to heal, how they are not just trading one drug for another, then it's going to be difficult for it to permeate society if the folks we look to for referrals and for support don't know it themselves. And so I hope there'll continue to be a big push on bringing this in as basic curriculum in some of these institutions of higher learning.
Thank you, Zach, for your time today. And we are going to conclude today's webinar. Your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefax and number the first time you register. After you register and sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be messenger@webex. The evaluation will close at midnight on Wednesday, May 22nd. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Office of State Courts Administrator for funding today's education. Have a great rest of your day, and please hold for the evaluation.